Hello friends. Today we're going to discuss about cluster A personality disorders as per DSM-5. I am Dr. Suresh Badadmat, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be discussing about cluster A personality disorder, what are the different categories, what is the diagnostic criteria, prevalence and management. Let's understand cluster A personality disorder. These are a group of personality disorder characterized by odd or eccentric behavior, unusual beliefs, and difficult to relating with others. They also have social aversion, failure to form close relationships, and poor insight. Under cluster A personality disorder, there are three important personalities disorders have been identified. One is paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. Like any other personality disorder, the symptoms will emerge in childhood and gets mature during adolescence and well formed by the young adulthood. Let's understand paranoid personality disorder. In paranoid personality disorder, there will be a pervasive distrust, suspiciousness on others that their motives are interpreted as malevolent and presents in a variety of context. That means it is not present in only one situation. It will occur in the occupational place, at home, at the society, and also even in the place of residence. And invariably, they need to have at least four symptoms to diagnose paranoid personality disorder. Let's look into these. Which are those important traits which have to be present to diagnose paranoid personality disorder? Usually, the paranoid PD suspects without any sufficient basis that other exploiting him, harming him, or deceiving him or her. They are preoccupied with unjustified doubts about the loyalty or trustworthiness of friends and associates. They are reluctant to confide in their others. That means they do not find very close relationship or confiding relationship in others because they feel that they may ditch them. They are fear that the information will be used against them maliciously to tarnish their image. Invariably, they also have hidden demeaning or threatening meaning into benign remarks or events. They feel the events occurring across him are pertaining to him. Persistently, they bear grudges and they are unforgiving of any insult, injuries, or slightest comment. They perceive attack on his or her character or reputation that are not apparent to others. They will quickly become anger and react to the situation. They have recurrent suspiciousness without justification regarding the fidelity of the spouses or the partner. And these paranoid personality symptoms shall not be secondary to any mental disorder, and it is present before the onset of any illness like schizophrenia. Then comorbid personality disorder with schizophrenia can be diagnosed. Let's move into schizoid personality disorder. Here in schizoid personality disorder, they have a pervasive pattern of detachment from social relationship, and they have a restricted range of expression of emotions in interpersonal settings, and they are present in variety of context, and they should have at least four symptoms to diagnose schizoid personality disorder. Let's look into those symptoms. They neither desire or enjoy close relationship, including part of the family. They almost always choose solitary activities. They have little interest or very few interest in having sexual experiences with another person. They take pleasures in few, and if there are any activities, that means they do not have much pleasurable activities. They lack close friendship or a confident person as a friend, either as a friend or a relative. They appear indifferent to the praise or the criticism. They show emotional coldness and detachment, or flattened affectivity can be seen. And above symptoms shall not be secondary to any mental disorder. And if these symptoms are present before the onset of any illness, then you need to make a diagnosis of schizoid personality disorder and also the mental illness. But you cannot interpret the primary illness to a personality disorder. Let's look into schizotypal personality disorder. Again, in schizotypal personality disorder, there is a pervasive pattern of social and interpersonal deficit marked by acute discomfort with and reduced capacity for close relationship, as well as cognitive or perceptual distortions and eccentricities of behavior and present in variety of context. Let's look into this eccentric behavior. They will have ideas of reference. That means it may not reach to the delusional level. They have odd beliefs or magical thinking that influences behavior and is inconsistent with subcultural norms. They have unusual perceptual experiences, including bodily illusions. They have odd thinking and speech. Speech can be circumstantial, metaphorical, over elaborate, or stereotyped. They may also have suspiciousness or paranoid ideas. They will also have inappropriate or constricted affect. Behavior or appearance that is odd, eccentric, or peculiar can also be noted. They lack close friendship and confiding relationship. They have excessive social anxiety that does not diminish with familiarity and tends to be associated with paranoid ideas rather than hating people. And above symptoms shall not be directly because of any mental disorder. If there is a mental disorder, and if you are able to diagnose the schizotypal personality disorder before the onset of illness, comorbid diagnosis can be done. Let's look into the prevalence. The prevalence of cluster A personality disorder you can see as per the National Comorbidity Survey Part 2 and National Epidemiological Survey on Alcohol Related Disorders. If you look at paranoid, it is between 2% to 4%, schizoid is 5% to 3%, and in schizotypal 4%. This is how the cluster A personality disorder is occurring in the society. Let's look to the diagnosis of cluster A personality disorder. How to differentiate between paranoid PD versus delusional disorder. Paranoid PDs will have a suspiciousness in multiple areas from adolescent to early adulthood, almost in every relationship, friendship, relatives, and also family members. But they do not have delusion. They may have overvalid ideas regarding to various aspects of life. That means it is enduring, affecting multiple areas of life, and they do not have delusion. If you look into the delusional disorder, there will be one delusion which you grant the rest of the symptoms can be explained on a logical basis. That means they are well systematized. The onset will be after 22 or 24 years. It will affect the relationship between the family members and also the family of origin. They will have invariably conflict with regard to the delusion. They are violent sometimes, litigious, and conflict with law is very common here. If you are able to neglect that one delusion, you may not find suspiciousness in other areas, whereas when presence of one delusion indicates towards delusional disorder. Now let's differentiate between schizoid personality disorder and schizophrenia. Again, schizoid personality disorder is an enduring pattern of traits where you can see social detachment, limited range of emotions, expression, likes to be solitary activities, no interest in relationship or sexual activity, and no psychotic symptoms. However, activities of daily living will be normal. If you look at schizophrenia, they will have delusions, hallucinations, disorganized behavior, impaired activities of daily living, biosocial occupational function will be impaired. If you want to differentiate between schizotypal PD and schizophrenia, in schizotypal PD, they will have odd, eccentric, unusual behavior, transient psychotic symptoms. Invariably, these symptoms are stable, enduring, reality testing normal, and overall functioning may impaired very little. Whereas in schizophrenia, the patient will have delusions, hallucination, disorganized behavior, impaired activities of daily living, and biosocial occupational function will be impaired. Let's look into the diagnosis of cluster A personality disorder. The gold standard is detailed evaluation by a trained clinician, clinical interview, observation of the person, and collecting collateral information from family members, relatives, friends, and partners. Sometimes you can use projective test to diagnose cluster A personality disorder. Invariably, the general personality disorder scales can be utilized, such as personality assessment and inventory, which is called as PI, structured clinical interview for DSM-5, that is KID-5, Minnesota Multiphasic Personality Inventory 2, that is MMPI-2, Millen Clinical Multi-Axial Inventory 3, Personality Diagnostic Questionnaire 4, and Schizotypal Personality Questionnaire, which is very specific for schizotypal personality disorder, can be utilized. Let's look into the treatment. For all personality disorder, the treatment is psychotherapy, medication, and combination of both therapy and medication. Unfortunately, there are no RCTs and any hardly studies with regard to paranoid and schizoid personality disorder regarding treatment, therapy. That means there are no RCTs. Hence, it is difficult to give recommendation based on evidence. Here, low dose antipsychotics and CBT have been tried, but the evidences are not strong enough to recommend them. There are few open label studies regarding schizotypal PDs have been noted. Let's look into this important review article published in 2018, Nature Partner for Journal for Schizophrenia. The title of the study was Diagnosis and Treatment of Schizotypal Personality Disorder, Evidence from a Systematic Review. This study was done by Krishner and his colleague. In this review article, they reviewed 18 articles on diagnostic instrument, 22 on pharmacological treatment, 3 on psychotherapy, 13 on the longitudinal course of the disease. With regard to pharmacological treatment, risperidone and olanzapine have been found to be beneficial in schizotypal personality disorder. The literature on psychotherapy is sparse and do not allow us to make any strong recommendation. Moderate remissions have been noted with regard to changing the diagnosis of schizophrenia has been noted in schizotypal. To conclude, my dear friends, the prevalence of purer form of cluster A personality disorders are very rare. Invariably, the presence of traits are spread across all the cluster A, B, C. The studies with regard to the personality disorders such as paranoid, schizoid, and schizotypals are very few. RCTs are nil almost. It is difficult to make any treatment recommendation based upon evidence. Most of it is clinical guidelines. Paranoid and schizoid PD can be given a low dose antipsychotics. However, the evidence towards indicating antipsychotics is very poor. Further, there are a couple of RCTs with regard to risperidone and olanzapine, and they have been found to be helpful in schizotypal personality disorder, my dear friends. Thank you very much for giving your valuable time. Stay safe.